Tintin with the Heart of Medicine. This is the ABIM Pearls video number 16. So for 16 days straight, we have done one video about all these different question sets. The idea is that you can continue learning internal medicine while you are walking the dog, in the grocery store, XYZ. And that's because there's a scarcity of these videos on the web. So I'll just walk you through the main learning objectives. It's not just going to be to read the learning objective, because that's not the point. I'm going to give you the information on why I got the right answer or got the wrong answer, what was the right answer, and why one answer was better than the second best answer. And I think that will give you a little more bang for your buck. So without further ado, let's get into the action here as I prepare for this certification examination. So this first question, all I want you to know is that they're telling you the patient had a coronary angiogram. It showed that there was significant stenosis in the anterior descending coronary artery, and the 85% are also significant obstruction of the right coronary artery. And nothing was done. It was a diagnostic angiogram because the plan was to take the patient the next day for a CABG procedure. But after the procedure, after the diagnostic angiogram, the patient became very ill. So the patient became very weak, having some back pain, diaphoretic, clammy, and blood pressure went down to 77/55 with a tachycardia of 122, regular tachycardia, okay? And they're saying that neck veins are flat, heart sounds are normal, chest is clear to auscultation, okay? They gave the patient 1 liter IV fluids. It didn't fix the thing, and don't expect it to fix the thing. They're telling you something is going bad, real bad. But of course, that's a temporizing adequate measure. So now the question is, what's the best next step managing in the patient? So you have to think, okay, what's going on here? So I got this question incorrect, as you are seeing. I didn't analyze it enough. So I was thinking, oh, maybe a transthoracic echo because this patient might have tamponade. Yes, that is a good idea if you don't take the context into account. When you read that the neck veins are normal, they're flat, heart sounds are normal, that's it. The question is clear, and everything that's written on the question is there for a reason. So that's telling you this patient doesn't have tamponade. Something else is going on. So what else could be happening? Well, what is usually what can be pretty life compromising will be a bleed. They're not saying the patient is bleeding out of the radial axis or the femoral axis. No, there can be an internal bleed, okay? And a retroperitoneal hemorrhage can happen. So if someone who is not that technically avid does a puncture above the inguinal ligament, you can have retroperitoneal bleed. And of course, that is the reason why it's so important to make sure always that if you go femoral, you make sure that you're going under the inguinal ligament. Because if there's a bleed under the inguinal ligament, it will not go into the retroperitoneal space and generate this havoc. So that's what they were trying you to think about. That's why the right answer was CT scan of the abdomen and pelvis without contrast, okay? Yeah, this is an emergency. You have to act fast. So that's why, and if it's a massive bleed like this, you probably don't need contrast, right? Okay. That's the main pearl from this question, and don't think we have to talk about much else. The only other option maybe to talk about is CT scan of the chest with contrast. If you're suspecting aortic dissection, of course, a CT angiography is the best one. And in an unstable patient, you wouldn't do a CT angio. You don't have time for that. You would do a transesophageal echo if the patient is unstable and you suspect aortic dissection. But the answer was not aortic dissection because it's very extremely rarer. So yes, of course, the tubing and the catheter is going up through the aorta, but the risk of you generating an iatrogenic aortic dissection is very low. You have to be even more inexperienced. Like the retroperitoneal hematoma can happen. It shouldn't, but it can happen. But for you to dissect the aorta, it means that you didn't put in the guide wire. You maybe forgot to put in the guide wire before advancing the catheter, or took out the catheter without putting in the guide wire through it. So these would be things that probably an inexperienced person would do, or a fellow that wasn't being well supervised. So that wasn't the answer. Okay, let's go on to the next question. This other patient is a patient that has all the findings for rheumatoid arthritis. So they're saying that the hands are frozen and tender every morning, has no weight loss, fevers, chest pain, or back pain, and there is mild swelling and tenderness of several proximal interphalangeal joints, metacarpophalangeal joints, and both wrists. All this is telling you, hey, this is basically rheumatoid arthritis. ESR is 55, so that's telling you about activity. So it is active. CRP would also be elevated, but they didn't give us the CRP. The patient has a negative rheumatoid factor and negative CCP. That doesn't mean much, of course. Most patients with rheumatoid arthritis will have a elevated positive rheumatoid factor and anti-CCP, but there's patients that don't, and there's patients that have seronegative rheumatoid arthritis. So that's the case here, and that's the answer. So let's see what other things we have here. Clinical features of rheumatoid arthritis. Yeah, remember that anything that says distal interphalangeal joint right over here, distal, that's not rheumatoid arthritis. That's gonna be something else. And for the test, it's usually gonna be osteoarthritis or osteoarthrosis. And laboratory findings, well, we already spoke about them. High IgM rheumatoid factor, positive anti-CCP antibodies, high ESR or C-reactive protein, talk about disease activity, and the X-ray showing soft tissue swelling, joint space narrowing, and bony erosions. Okay, so that's about it for this question. And let's see what else we have. Other inflammatory markers useful in diagnosis of RA or useful in excluding other conditions include anti-nuclear antibodies. So the ANA will tell you, hey, let's think about something else if that's elevated. This might be lupus, for example. C-reactive protein, that is elevated with rheumatoid arthritis activity. It is usually elevated. and serology for viral hepatitis and parvovirus B19. So yeah, parvovirus B19 can generate these symptoms, but it usually is common infections in adults and children, and it will give you some symptoms that will resolve quickly and rarely last more than 6 weeks. Okay, and that's it for this question. Let's go on to the next one. This next question is interesting because it makes you think about how to diagnose mononeuritis multiplex. So if you have a patient, as you can see here, the most voted options were mononeuritis multiplex and multiple sclerosis. I oftentimes find it difficult, a little bit difficult to differentiate multiple sclerosis from mononeuritis multiplex because you know that multiple sclerosis gives you CNS white matter problems, right? Demyelination, um, plaques, or yeah, problems. So this will give you asymmetrical, multiple sclerosis gives you asymmetric findings, neurological findings. And mononeuritis multiplex, as the name states, it's one neuron or one neural path, mononeuritis, multiplex meaning many different neural pathways in different places. So both multiple sclerosis and mononeuritis multiplex are asymmetrical. So they'll give you, oh, that's weird. This having this upper extremity symptom right here and having this other thing in the left lower extremity, things that don't add up usually. So the difference is that mononeuritis multiplex affects the peripheral nervous system and multiple sclerosis affects the central nervous system. So with multiple sclerosis, you would be expected to find more things such as not only muscular, not only sensitive, you will also find things such as bladder problems, some constipation or things like that, eye visual problems, optic neuritis, and things that you won't see with mononeuritis multiplex. So what's the gist of this? Mononeuritis multiplex is a painful, asymmetrical, sensory and motor peripheral neuropathy. It affects two or more nerves in different parts of the body and is most common in patients with vasculitis, connective tissue disease, or systemic disorders such as diabetes. Okay? Why wasn't it multiple sclerosis? Multiple sclerosis usually occurs in patients age 15 to 50. So not very old age, but of course it is young age to mid age. Patients commonly present with two or more distinct episodes of central nervous system dysfunction with partial or complete resolution. Multiple sclerosis does not affect the peripheral nervous system. That's it with this one. Let's go on to the next question. This next question, the clinical pearl or objective is that you are able to see that this patient is having bicytopenia. So cytopenia in two different cellular lines. So this patient has anemia, hemoglobin is 8, and it is macrocytic. So it is macrocytic anemia. MCV is is 114. And platelet count is normal, but leukocytes are 3,400. So this patient has anemia and leukopenia, okay? And look at the differential, 66% neutrophil, sort of normal. 20% lymphocytes, it seems like a little bit lower on the differential. Why is that? Because monocytes are elevated. Okay, just something to consider there. And the rest of the labs are basically normal. So this is a 73-year-old male patient having 2 months of worsening fatigue. And these are the findings the patient has in his complete blood count. So the question is asking you basically, they are giving you, since the patient has macrocytosis, they are giving you the TSH levels, which are normal, folate levels are normal, vitamin B12 is normal. So they're basically telling you this macrocytosis is not due to the common culprits, which are going to be B12 or folate deficiency. They also give you a peripheral blood smear showing ovalomacrocytic red cells and reduced granulocyte segmentation. And complete blood count was normal a year ago. So which of the following is the most appropriate next step in management of this patient? What you have to think is what's going on? What's the diagnosis? So this is a diagnosis of exclusion. So when you exclude many things, you might end up in this same place where you're like, maybe this is myelodysplastic syndrome, MDS. And if you suspect myelodysplastic syndrome, you always have to go and do a biopsy, bone marrow biopsy. So that is why the correct answer here was bone marrow biopsy. And let's just see what's the importance here of myelodysplastic syndrome. So, of course, the patient can be asymptomatic or have symptoms due to the cytopenia the patient is having, such as anemia or the thrombocytopenia or the granulocyte dysfunction, depending on what they're having. And clinical features, you have refractory cytopenia with single lineage dysplasia, or it is refractory anemia with ringed sideroblasts, or refractory cytopenia with multi-lineage dysplasia. You get the point, okay? So, what's the other thing we have here? Yeah, it did tell us that the patient drank a little bit of alcohol, but it wasn't probably enough. It was just like 1 to 2 cups of wine every I don't know how often, but it didn't sound like that was going to cause it. And it is very infrequent that alcohol abuse will cause an MCV above 110. So that's also probably part of the picture, guiding you against alcohol-induced. So diagnostic evaluation in myelodysplastic syndrome requires peripheral blood smear and bone marrow aspirate or biopsy to assess for dysplastic cytologic features consistent with MDS. And that's the answer. Let's go on to the next question. This next question is a nice one because it gives you the anatomy here and a picture, and these are nice if you know your pictures. If not, it can be a little bit more complicated. So this question I would often get wrong in the past. Now I'm not getting it wrong that often because now I'm understanding what this looks like. So when I would see this in the past, I would think about it and I would be like, yes, I would know that this is associated to sun exposure. Yes, that is a problem. But I wasn't sure if this was seborrheic. What I was usually between seborrheic dermatitis actinic keratosis, and I wasn't able like to differentiate those two. But now, yes, now I understand that this is actinic keratosis. And the way actinic keratosis looks like, keratosis means just like the keratinocytes, right? Kerato is a little bit like hardening, I think, keratosis. So if you pass your hand on this, you'll feel it's a little scaly. Actually, part of the physical examination in this, in actinic keratosis, sometimes is passing your hand, because some of these lesions are like not very easily seen. So it is recommended to pass your hand, and maybe you can feel a little bit about of the like keratosis here, right? The sandpaper sort of consistency, and be like, oh, maybe there's some actinic keratosis under this, right? But the other thing is that it has this like whitish sort of tone to it. So that was the right answer. It was actinic keratosis, and let's review the main points here. So actinic keratosis often presents as rough, scaly, erythematous macules or papules, which that are most commonly found on fair-skinned individuals. Sun-damaged skin and chronic sun exposure are major risk factors for development of these lesions, accounting for their usual detection on the balding scalp, face, lateral neck, and distal upper or lower extremities. Okay, so that was it. And remember that it is a pre-malignant lesion, meaning that it can convert into malignancy, so you want to treat it before it becomes squamous cell carcinoma, for example. The likelihood for conversion or progression to squamous cell carcinoma is low. Approximately 60% of cutaneous SCCs, or squamous cell carcinomas, arise from pre-existing actinic keratosis. So yes, every actinic keratosis, pay attention to it, because most of the squamous cell carcinomas you find out there were some sort of actinic keratosis at some point in time. And what else do you have to do? Biopsy is indicated if the diagnosis is unclear, or for lesions more than 1 centimeter in diameter, indurated, ulcerated, tender, or rapidly growing, okay, or fail to respond to therapy. So how do you treat the actinic keratosis? It usually includes destructive therapy such as cryosurgery, curettage, shave removal, also topical medications such as 5-fluorouracil, imiquimod, and photodynamic therapy. How do you prevent it? With sunblock and avoiding sun exposure as possible, protective clothing. And that's it for that one. I'm just going to show you a couple more images so you can be able to differentiate actinic keratosis from seborrheic dermatitis. Like most times, the question will ask you on the test, if this is seborrheic dermatitis, you will see a face. You're probably going to see a face, and you're going to see this sort of imaging. So you can see right here, it does not spare the nasolabial folds. So that sometimes is going to be also a differential with the lupus malar rash, because lupus malar rash does spare the nasolabial fold. What's special about seborrheic dermatitis? It affects areas of the body rich with sebaceous glands, such as the face, scalp, and chest. So areas are pruritic and develop erythematous plaques with fine, loose, greasy scales. Dandruff is mild form of seborrheic dermatitis. Okay. Then we have seborrheic keratosis. This is different. This is cerebriform. Looks like a brain right here. So it says benign growths that have a warty cerebriform stuck-on appearance. And solar lentigens or lentigines, or however you pronounce that, that's just like the usual freckling, right? But way more manifest, right? So that's the solar lentigens. How do you pronounce that? Not sure. It's also known as H spots or liver spots, are benign, asymptomatic, pigmented macules that appear in fair-skinned individuals or on sun-exposed areas of the skin, face, upper chest, shoulders, forearms, and dorsal hands. Okay. And that's it for this one. Let's go on to the next question. This other question is just asking you, when do we start treatment, or what's the treatment for a patient with mixed hyperlipidemia? So this is a 36-year-old male who is healthy, basically healthy. Physical examination is normal, but the fasting laboratory results showed total cholesterol of 255, LDL 125, HDL 60, triglycerides 346, and glucose of 92. Okay, so basically he's here for a routine visit. You just got the labs. These are the results. You did a ASCVD risk score. 10-year risk of cardiovascular disease is approximately 1%. So it says, in addition to lifestyle modification, which of the following is the most appropriate next step? So it's asking you, okay, what will you treat? Will you treat something? Yes, no, and if so, what? And that's your question. So in summary here, you have to understand that if your LDL is not above 180, like whenever it's above 180, you just go ahead and treat. 180, 190, you just go ahead and treat. But if your LDL is elevated but below, yeah, like 180, I don't remember if it's 180 or 190 right now, let me know. You go and do the ASCVD risk score. So if it's low risk, meaning 10%, meaning 10-year cardiovascular risk, you don't treat it. You do lifestyle modifications. And now the other thing to take into account is, what do you do about the triglycerides? So the triglycerides are 346. They're elevated as well. Do you treat them? Well, the answer is you do lifestyle modifications first. If your triglycerides are less than 500, so there's the trick. So in this patient, you don't treat, you don't give anything other than lifestyle modifications, and then you follow up to see how they are doing. Okay, so that was the right answer. So this is the algorithm of what we just talked about. Well, this is focusing on hypertriglyceridemia. So hypertriglyceridemia, you evaluate for secondary causes, okay? And after that, you see the number. If the number is between 150 and 500, you do lifestyle modifications. And of course, if you already have cardiovascular disease or have high risk for cardiovascular disease, you start a statin. And that's one side. On the left side of that algorithm. On the right side, if you have triglycerides over 500, your initial goal is to prevent pancreatitis. So pancreatitis risk starts after triglycerides are above 500, so you have to treat that. But it really, really rises steeply once triglycerides are above 1,000, right? So you don't want to let them get to 1,000 at all. Initial goal is going to be fibrates, fish oil, or abstinence of alcohol, okay? And that's the main pearl for that. We also have this little table that is telling us about indication for statin therapy. You have statins for primary prevention and for secondary. So for primary prevention, that's what I told you. If LDL is above, it's 190, you just treat it. If age is above 40 with diabetes, you treat it. You give a statin. You don't care about the lipid profile. Of course, check it, but you don't really care about it. Estimated 10-year ASCVD risk is more than 7.5 to 10%. You do a moderate to high intensity statin. And now for secondary prevention, meaning the patient already had established cardiovascular disease, you just treat it. So if the patient is younger than 75, you do high intensity statin. If the patient is older than 75, you do moderate intensity statin just to avoid some of the risks of a higher dose of statin in the older age. What is cardiovascular disease? It's whatever peripheral artery disease, TIA, arterial revascularization, stable angina, coronary artery disease. And let's go on to the next question. So this next question is, this question is important because it's basically trying to get us to diagnose and differentiate between two different things. One of them is polymyalgia rheumatica and the other one is hypothyroidism. So how can we differentiate these two? Well, polymyalgia rheumatica, it's pretty, the symptoms are, remember, proximal muscle weakness here, like centripetal in the trunk, proximal here, and also in the hips, okay, hip area. And you're just going to have the muscle pain. You're also going to have an elevated CPK, I believe, or ESR. ESR will be elevated, and CPK, creatine kinase, no, it's not going to be elevated necessarily, but the ESR will be elevated. Okay, so that's polymyalgia rheumatica. Why? And I got it incorrect. I thought it was hypothyroidism because the TSH in this patient was 8. So I'm like, okay, this patient has muscle pains and also has some, TSH is 8. So this has to be hypothyroidism. So I inclined more towards hypothyroidism than polymyalgia rheumatica. But what they were telling us in this vignette is that this patient could have had a subclinical hypothyroidism. So they weren't giving us the T4. So we didn't know how T4 levels were, and we weren't sure if this was clinical or subclinical. So yes, it was a trick, and that's why 17% of us marked this question incorrectly. So let's focus on the right answer. So polymyalgia rheumatica causes proximal muscle aching and stiffness in elderly patients and responds rapidly to low-dose prednisone. Why wasn't it hypothyroidism? So hypothyroid myopathy is characterized by myalgias, weakness, and elevated creatine kinase. So the CPK is elevated in the muscle pain due to hypothyroidism, but not to polymyalgia, and this patient's CPK was normal. So this patient's mild elevation of TSH more likely due to subclinical hypothyroidism, which is not associated with her degree of symptoms. That's about it. So what's the dose of prednisone you give in a patient with polymyalgia rheumatica? It's going to be about 15 to 20 milligrams per day. So it's sort of low dose, right? Compared to things you see out there that are way higher. Lack of a prompt response should call the diagnosis into question. Although there are no specific laboratory studies to confirm the diagnosis of PMR, polymyalgia rheumatica, age of onset, elevation of ESR, and rapid response to prednisone will differentiate from other myopathies. And that's about it for here. With polymyalgia, you can also have an elevated CRP. What else do you have here? That's about it. Let's go on to the next question. This next question is an interesting one. So here you see the axilla of a patient, and you can see that there's a sort of a rash, and there's like hyperpigmentation, right? There's like hyperpigmentation in the axilla. So they're asking you what's basically the diagnosis here. So they threw a little bit more information into the mix, because if they only showed this, actually it would be a tough diagnosis. But they added the Woods lamp here. So this is what clarified the diagnosis. So examination with Woods lamp shows red fluorescence in the affected areas. So this is something I learned, because whenever I would hear Woods lamp, usually what I thought about was the malassezia furfur associated with, what was this condition? It was the one associated with people that put on oil on their body and then sunbathe. It's called the tinea versicolor, right? Or versicolor tinea. But Woods lamp will help you distinguish in other things. So in this case, the red fluorescence on Woods lamp with these findings would be concerning for erythrasma. That's why that's the right answer, erythrasma. Erythrasma will be red-brown plaques, most commonly in the interdigital or intertriginous areas. It is caused by Corynebacterium minutissimum, which is a bacteria. And of course, Woods lamp will show coral red appearance. And the treatment for this is to reduce moisture, and topical antibiotics such as clindamycin can help. Also, topical antifungals can potentially make the trick in limited disease. And that's about it for erythrasma. So it's probably going to be a little bit difficult to differentiate from other things, but the Woods lamp findings here definitely helped. Because if I show you the image here for inverse psoriasis, So now we differentialize inverse psoriasis. So when you think of psoriasis, it's usually occurring in extensor areas, right? Why is this called inverse psoriasis? Because it's just the opposite. It's not in the extensor areas, but now it's in the intertriginal areas mainly. So that's why inverse psoriasis is called inverse psoriasis. It's not the usual pattern of location of this condition, but here you can see that inverse psoriasis looks pretty similar. Like there's hyperpigmentation in the axilla right over here, but the difference is that Wood's lamp wouldn't show anything special there. And what else can we have here? Um, okay, what else? The plaques are also erythematous and well demarcated, but may not have the typical psoriatic scale and are frequently not pruritic. The lesions do not exhibit any fluorescence under Wood's lamp. Okay. Another option here is tinea. Well, tinea due to microsporum. Microsporum is one of the three most common causative agents. Tinea is sort of easy to distinguish. You'll just see an active border. So you'll see that there's something going on, sort of maybe circular, and the border is more active. Yeah, that's tinea. So what else do we have? And that's it for this question. Let's go on to the next one. So this other question over here, what they want you to be able to diagnose is splenic vein thrombosis. So how do you diagnose it? Well, in this specific question or vignette, they're telling you that this patient has had some recurrent abdominal discomfort, and the patient also has an x-ray. And look at this. X-ray shows focal calcifications anterior to the spine over the epigastric area. When I read that, I wasn't sure what to make about it. I wasn't sure what organ they were asking me about. But if you take that into account in the context of what they're asking you, then it makes sense, because the upper GI endoscopy revealed normal esophagus, but some gastric varices in a specific place in the fundus. Rest of the stomach was normal. When you have varices only on the fundus, that is telling you something is going on with the splenic vein, because that is the distribution of the splenic vein. So if you have thrombosis of the splenic vein, you will have gastric varices only on the fundus. So if they gave you that information, that's for you to think about. And now you can understand why there were focal calcifications in the anterior epigastric area, which was due to chronic pancreatitis. Because chronic pancreatitis, of course, is associated with chronic inflammation. And one of those pathophysiological findings in pancreatitis is going to be the calcium deposition in those tissues, in the pancreatic and surrounding tissue. So that's going to give you the calcification on the x-ray. And pancreatitis will also inflame that area near the splenic vein and increase the risk for splenic vein thrombosis. So that's why that was the answer. Okay, let's see what we lost here. Well, here you have the imaging. Now you can make sense of why the splenic vein and gastric fundus will be affected with the varices. And of course, they can bleed or not bleed. And that's showing you that area there. It would have been nice probably to add the pancreas there, but remember that the pancreas head will be right over here, and it's going to be like right over here. It'll get up to here. So inflammation of that will probably alter this area right over here. And that's it. So let's go on to the next question. This other question, what do they want us to learn? Okay. So the pearl in this question is that you didn't have to read the whole thing to probably get this question right, because look at this. If you just go to the options, you see, order endorectal coil MRI, reassess in 6 months, repeat PSA, schedule transurethral ultrasound with biopsy, start tamsulosin. So now you know they're asking you something about the prostate. So if you see the digital rectal examination, it says prostate is mildly enlarged. There is a firm 1 centimeter nodule in the right lateral lobe of the prostate. So that's good enough. Whenever you find any abnormality in the prostate, that if it's asymmetrically enlarged or there's a nodule, you have to go and get a biopsy. And that's about it. So that's what this patient needed, because even if the PSA is normal, but DRE is showing you some concerning findings, you have to go get the biopsy. If you have an elevated PSA and your prostate on digital rectal examination is symmetrically enlarged, yes, it can be benign prostatic hyperplasia. But if there's, of course, asymmetry or a nodule with or without elevated PSA, better go get that biopsy. Of course, if the PSA is higher, the higher the probable risk of something going on, right? So that's the right answer. Indications for transrectal ultrasound prostate biopsy. Indications will be, for initial biopsy, what I said, DRE showing prostate nodule in duration or asymmetry, independent of the PSA. Rising PSA level, usually more than 4. Velocity or rate of change, of course, elevated, and the PSA or density. Indications for repeat biopsy, so inadequate sample size on initial biopsy or continued high clinical suspicion based on normal PSA or symptoms, abnormal histology on initial biopsy. And that's it for this question. Let's go on to the next question. This other question is interesting. I liked this one because now I'm starting to be able to diagnose or differentiate CIDP from Guillain-Barré. So it's Guillain-Barré is AIDP. So Guillain-Barré means acute inflammatory demyelinating polyradicular neuropathy, while CIDP is basically the same thing, only that chronic. But sometimes it's a little bit difficult to differentiate these two, because in my mind, whenever I see a clinical picture that goes in hand with the usual Guillain-Barré, I just mark Guillain-Barré and I don't even look at the other options. Well, remember that whenever you have something very similar to Guillain-Barré, but it has lasted way more, it's basically going to be CIDP. So this patient started 6 months ago with tingling and numbness in his feet, and that's the usual pattern, right? It starts in the longest or the most distal part. It's going to start usually in the feet, then you're going to have symptoms in the hands, and then it might advance proximally. Stocking glove pattern, I think that's what step 1 said, right? And let's see. Demyelination. So CIDP, there's a acquired inflammatory disorder characterized by demyelination of the peripheral nerves and nerve roots. Classically presents with progressive symmetric proximal and distal muscle weakness along with distal sensory loss affecting the arms and legs. Symptoms typically develop over 8 weeks, which helps to differentiate CIDP from AIDP or acute inflammatory demyelinating polyneuropathy. Distal sensory loss is normally more selective for vibration and proprioception due to the greater involvement of larger myelin fibers. Diminished or absent deep tendon reflexes is also characteristic. Diagnosis is made clinically and supported with electrodiagnostic studies. So the neurologist will do the nerve conduction studies and all those things showing reduced conduction velocity and prolonged distal motor latencies. And the lumbar puncture will show the same as Guillain-Barré, which will be albuminocytologic dissociation in 90% of patients. So why wasn't it AIDP or Guillain-Barré syndrome? Because Guillain-Barré usually reaches a nadir within 3 to 4 weeks. So the max, is going to be 3 to 4 weeks. AIDP is also usually associated with antecedent illness such as Campylobacter jejuni infection, HIV infection, or vaccination. And that's it for this one. Let's go on to the next question. Okay, so this is a good question because, I wasn't varenicline, right? Varenicline, it's a great medication for smoking cessation. So if you have to choose one medication that doesn't have contraindications for smoking cessation, the best one is varenicline, okay? I think is it Chantix? I don't like to learn the brand names, but I think many people here probably will recognize it as Chantix, right? Let's see, Chantix, there you have it. So that's the medication, and the question here was basically for you to be able to recognize when to give and when not to give the medication. So I did recall that varenicline was associated with cardiovascular outcomes or cardiovascular disease. So as you can see, I marked that question. I said avoid it because it is associated with cardiovascular disease. And this patient had a coronary artery disease and myocardial infarction 4 months ago. So I'm like, nope, this patient is a contraindication. But the learning objective here is that the risk of not starting it outweighs the benefit. So basically, it's better to do Chantix or varenicline, despite it has some cardiovascular outcomes, but you ensuring that the patient will stop smoking and reducing the risk, cardiovascular risk that conveys over just having to deal with the cardiovascular risk of the medication. So here we have that varenicline is a partial agonist at the alpha-4 beta-2 nicotinic acetylcholine receptor and the most effective single intervention for smoking cessation. And history of depression is not a contraindication to varenicline treatment. So that's also important to note. However, a cautious approach would suggest discontinuation of varenicline if any new neuropsychiatric symptoms emerge soon after starting the medication. Varenicline should be avoided in patients with current unstable psychiatric status or recent suicidal ideation, okay? So that's in the psychiatry ward, probably you won't find any patient on varenicline, or if they were on varenicline, the medication will be stopped because that's where you want to stop it. But it shouldn't be stopped basically with other indications. So in patients with known cardiac disease, yes, there is risk, but the risk is minimal. Any risk is likely outweighed by the benefits of smoking cessation, and cardiac disease is not an absolute contraindication. There you have it. So that's it. Let's go on to the next one. This next question, okay. Oh, all these questions are interesting and you learn a whole lot from each and every one. So in this question, they're basically wanting you to diagnose a condition based off of the findings. So I'll just give you a couple clues. So this is a 32-year-old man who has malaise and fatigue for about 3 months, has had a 5-pound weight loss in the past month, and a lifetime non-smoker, and has some right upper quadrant tenderness. Basically, we have some labs here. Labs are showing alkaline phosphatase is 520, total bilirubin is 3.3, direct bilirubin is 2.7, AST is 72, and ALT is 64. And ultrasonography shows no gallstones and no common bile duct dilation. Liver biopsy reveals intrahepatic ductal obliteration with moderate lymphocytic infiltration and periductal onion skin fibrosis. Which of the following is the best next step in management of this patient? So first thing you have to do with this information is be able to understand, okay, what's the diagnosis of this? So after what we just read, we're seeing that 2 things should come to mind, right? It should be PSC, primary sclerosing cholangitis, or PBC, primary biliary cholangitis, or what was known in the past as primary biliary cirrhosis. So when you think of those 2, now you have to convert it into one. Now you have to think, is this PSC or PBC? And that's where I wasn't able to make the distinction because I just probably ran out of time or wasn't going to get it right. But in this specific case, the answer is it is PSC. It's primary sclerosing cholangitis. And how do you know this? Well, PSC there's no problem. It happens in males all the time. PBC happens 90% in females. So it's not PBC, it's PSC. And PSC can be intrahepatic ducts affected and extrahepatic, both of them, while PBC is only intrahepatic. And this onion skin fibrosis, I think, is more of PSC. And there's a couple more things. PSC could be associated with P-ANCA positive, while PBC usually, they don't mention that association. PSC is treated with ursodesoxycholic acid, while PBC is not treated with ursodesoxycholic acid. So that's why the answer here was, oh no, no, I got it, primary sclerosis. Next step, no, sorry, PBC is treated with ursodesoxycholic acid. Let's see. PBC, option E. Ursodesoxycholic acid is a mainstay of treatment for primary biliary cholangitis, which can present similar to PSC. However, PBC usually affects women, 90% of cases, and biopsy shows mononuclear cell-mediated destruction and or periductal granulomatous inflammation of intrahepatic bile ducts. Ursodesoxycholic acid does not have a clear role in management of PSC, so that's why it was not the answer. So why was it colonoscopy? Why was the answer colonoscopy? Because primary sclerosing cholangitis presents with cholestasis and can reveal intrahepatic ductal obliteration with moderate lymphocytic infiltration and periductal onion skin fibrosis. Most patients have comorbid IBD, inflammatory bowel disease, usually ulcerative colitis, and a significantly increased risk of colorectal cancer. Colonoscopy is recommended in all patients to diagnose underlying IBD for colorectal cancer surveillance. So, whenever you have a patient with PSC, primary sclerosing cholangitis, you immediately do a colonoscopy. And after that, if you find that the patient does have inflammatory bowel disease, you will do a colonoscopy every 1 to 3 years for surveillance. Okay, that's basically it. 1 to 3 year surveillance colonoscopy. If you do not find any inflammatory bowel disease, you will do a colonoscopy every 5 years, and that's the information that is up here. Here we have it right here. So let's go on to the next question. Okay, and that's about it. We already talked about this. That's about it. Go on to the next question. So liver transplant is the treatment for basically PSC. Let's see what else we were missing for treatment for PSC. Endoscopic dilation and stenting of strictures, screening for cholangiocarcinoma and colorectal cancer, and liver transplantation in advanced disease. Okay, go on to the next question. Oh, last question. Good. So this question, tough one. I got it correct, but I didn't, maybe all the reasoning through it, I didn't have it like quite clear after I read it. But this is important because it's telling you, okay, in a patient that has third cranial nerve palsy, okay, oculomotor nerve palsy, what is the workup? So if you have oculomotor palsy, you can differentiate it in two. You have to actually distinguish it in two. Is it pupil sparing or is it non-pupil sparing? So this is an important distinction because non-pupil sparing oculomotor cranial nerve palsy means that the pupil is affected. And remember that the third cranial nerve through the parasympathetic nucleus of Edinger-Westphal generated constriction of the pupil. So if you have a patient that has the left eye is down and out, and the pupil is dilated compared to a more constricted right pupil, and you see that the right pupil with light, it closes up, and the left pupil with light, it's not constricting, that means it's a non-sparing third or oculomotor cranial nerve palsy. What that means is that the Edinger-Westphal fibers are more on the outside of the nerve, so I'm going to show it to you right here, are more on the outside of the nerve. The parasympathetic, you see, are on the outside of the nerve, and that means that there is extrinsic compression, so something is actually present on this from the outside. So it could be an aneurysm. That's the most common thing that can be going on. And that's why you have to do an MR angiogram of the vessel so you can rule out aneurysm or also detect if there's something there, a tumor present on the peripheral aspect of the nerve. Meanwhile, if you have the same patient that has these symptoms, right? For example, you can have other conditions generating this. So the pupil sparing oculomotor third nerve oculomotor palsy, you will have the eye that is down and out, but the pupil is able to constrict normally. It usually means that the parasympathetics on the outside are normal, pupil is normal, but the inner part is affected. And why is the inner part affected, or the nerve affected? Because of ischemia, or ischemia due to, here you can see it, the vasa nervorum, right? For example, diabetic ophthalmoplegia or chronic hypertension or things like that, ischemia in general. So that's what I wanted you to think about. So pupil sparing third nerve palsy is typically caused by microvascular ischemia associated with diabetes, hypertension, hyperlipidemia, and advanced age. Observation and supportive care may be appropriate in patients with vasculopathic risk factors, although some physicians advocate for imaging to exclude mass effect with all third nerve palsies. Okay, now you know the reasoning through this and why the correct answer here was to do the MR angiography of the head. And that's it for this one, and I'll see you in the next episode. And yeah, let me know comments, feedback, opinions, everything. See you in the next one. Peace.